First off, I want to thank the brave men and women who work behind the wall. I want to thank them on a national level because their job goes unrecognized.
How do they try to turn a guard?
Well, correctional officer. Sorry, I apologize. But correctional officer. How you guys doing today? It's Anthony Gangi. Welcome to another episode of Tier Talk. Guys, we're going to be talking about something that is, it's something that everybody wants to know. We're going to be talking about coronavirus in the prison or the jails. Basically, how it can get in there, what are preventative measures, if it does happen to happen in the facility, what are we doing to make sure it doesn't spread? There's a lot to cover. That's why I'm actually going to have some help on this one. So again, I have Connie, Alleyne. We've seen her many times. And I also have retired major and now a college professor, Soto. Connie, do you mind introducing yourself to our audience again?
Sure. Hi, I'm Connie Alleyne. I am the founder and president of the Civilian Corrections Academy. I'm actually quite excited to kind of talk about this, not just because it's in the medical wheelhouse, but just because I think, sometimes we try to, I want to say we try to normalize some of the things that are going on out in the community, and we only see it get huger as it's in the facility. And so I think for us to put some context to the coronavirus would be great.
I think you're the first person I ever saw smile when I said the word coronavirus. Look at it. It's great. And then I thought we can have from a custody perspective, because there's definitely going to be a partnership between medical and custody. Our retired major, who's now a college professor, Soto. You mind introducing yourself again?
Hey, welcome, guys. How we doing again? Retired major Soto, now professor over at Rutgers University, and I'm so eager to talk about this topic because it's here and now. So we need to be prepared.
Hey guys, I've been getting requests for this. Trying to put this together, I realized that we really need to have a roundtable discussion. I mean, this really can't be done by one person. And I also think that there's a lot of stuff that we haven't discussed yet. So I want you guys to be advised that we may be kind of thinking of it as we go. So we're going to be kind of figuring out which perspective, because I may not know which way Connie's going, which way Soto's going, but I think honestly, it's just a matter of just be constructive and actually try to have an end game. And we're not going to have the answers to everything, guys, but it's just good to have the topic, and maybe we'll get the answers to some things. If we don't know it straight out, maybe all three of us can figure it out together. Now, guys, if you happen to show Tier Talks for you brave men and women that work in corrections, so please subscribe, interact, engage, comment, hit that bell. That bell's going to notify you every time I post a video. We'll go to our sponsor. We'll come back, and we'll dive right into the coronavirus. Hold on. We're going to talk about the coronavirus. I don't want to dive into no coronavirus. So we'll talk about the coronavirus. Stand by for our sponsor.
I wanted to attend a university that had an intelligence program. I wanted to look at problems different. I wanted to increase my critical thinking abilities. AMU offered those avenues to expand. Obtaining your degree as an adult, you're actually paying yourself and investing in yourself. You can't put a dollar on it. It's priceless. It's something that can never be taken away from you.
American Military University. Learn from the leader.
Guys, Inmate Manipulation is a course that is highly needed. It's the process that's so slow moving and subtle that you don't realize it's happening. When inmates choose to manipulate, they manipulate our need to react. Situational awareness and insight is going to save your career. It's going to save you from doing foolish things. Listen to your gut. So the more insight we have, the more we can recognize what isn't so overt, and we can correct our behavior before we fall into a trap that we can't get out of. If you allow an inmate to pull you out of your prescribed role, you are opening up a door for a host of problems. Inmate Manipulation, the psychology behind inmate manipulation. Available now. Link in description. All right, guys, and we're back. So I thought what we could do first is, I'll go to Soto first, because there's two different perspectives. So after Soto answers it, we'll go to Connie, and then we'll go to Connie, and then Soto, and kind of go back and forth. But the first thing I want to talk about is how the coronavirus could possibly enter either a jail setting or a prison setting or even a community release setting. So, Soto, what would be your concerns about the virus coming into your facilities?
just like everyone else, we think that we work in an environment where we are protected, where we are confined, but unfortunately, we are always touched by outside factors, anything that can happen. And we learned that a few years ago when we thought, we had everything covered under policies and procedures. And lo and behold, something we didn't think about in New Jersey that could happen. And that was an earthquake. And it came through and no one knew what to do at that point because we didn't have any policies in place. For this particular reason, most of our places have a policy that deals with pandemic or influenza, and we're going to probably piggyback on those things in order to combat anything that may happen now. When you think about how can it get into our jails, how can it get into our prisons, the most and easiest way is by being contaminated of people that are coming in and out of our institution every day. It could be our employees, it could be our civilian employees, our custody employees, it could be during the visits, right? Visits, we don't know where these visitors are coming in and out and where they're in contact with. There's various ways that it can be introduced into our prison population. So those are some of the common ways. I'm sure Connie can add to some of those as well.
And I want to add, before we go to Connie, I also want to add that we also have contract vendors that come into the facility, volunteers. So basically, even though a lot of people think the prisons and jails are shut off from the community, there is a lot of traffic that comes in, obviously, And again, you also mentioned the jails got a lot of inmates coming in and out every day. So there's just a lot of stuff coming from the outside coming in. We're not as closed off as people think we are. But what's your thoughts on that, Connie? Are we missing anything?
So, I think also too, just through appointments. Inmates have many medical appointments where they're going back and forth all the time. They go out into the community. They go into these different community centers or like health centers or hospitals. And you would like to think the same precautions or even higher, an elevated sort of level of precaution is being taken. But you just never know who they're exposed to as they're in transport. So I think that's one thing we want to just mention, because some facilities do a significant amount of transport because internally they're unable to manage a lot of the offender needs.
Hey, Louis, just to piggyback on something, we didn't touch the community release stuff. What would be any difference in traffic there with the community release? They get a lot more traffic than you would see with the jails and the prisons?
Yeah, those community releases and half houses and stuff like that, we have the same schedules and routines that a prison does with a lot more freedom sometimes. Some of these residents, we call them residents at our halfway houses, they go out to the workforce. So they go out to work and they return to our facilities. They have visits just like everybody else. There's also a lot of volunteers. A lot of volunteers come in, whether it be religious, whether it be programming, and they come into our facilities every day. So there's a lot of contact with the community, and those things can, aid and assist in viruses getting their way or making their way into our populations.
Hey, good point you brought up too. By the way, a lot of prisons also have outside details that go into the community.
Yeah. But I think one thing I wanted to add too that I just don't want us to gloss over is that jails and prisons were established or constructed, right, for maximum public safety. They weren't necessarily constructed to minimize transmission of disease or even be a space where you could effectively sort of provide healthcare. So the fact that this environment is already just compromised from that perspective, I think makes it a much more important topic for discussion.
That's a great perspective, because obviously we have a lot of people in a smaller area, especially when you have those dorms or 2 people to a cell. Now, Connie, Soto touched up on something where he said we kind of have slight preparations because, we've dealt with influenza, maybe tuberculosis, MRSA, but would you expect a difference in response when dealing with the coronavirus?
So I think because it's something fairly new, that most facilities have these exposure plans, and they're very explicit. They're very detailed. It's usually a combination of what the CDC is requesting or requiring, what the Department of Public Health is requiring. There's usually a very collaborative effort to get the best standard or the best way to contaminate when you have something like this. I don't know what the current protocols might be for corona, but I would assume that it would be different, seeing as the number of people we've seen die from it.
Well, let me ask you a question from a medical standpoint, Connie. Let's talk about how those different diseases spread. So let's talk about the TB. Let's talk about the MRSA. Let's talk about influenza. And then would you know by any chance the difference between how influenza may spread as compared to the coronavirus?
I don't know the difference between that. I do know that, say with tuberculosis, for example, the particles are coming out. So there's been a lot of conversation about whether or not wearing a mask, like the regular surgical mask, is appropriate. Does it actually serve as a barrier for transmission? And many articles say that it doesn't, some does. I mean, I think it depends on the quality of probably the mask that's being worn. That may be a way that you can prevent the spread. But our reality is that we are in an overcrowded space. We don't have access to certain resources. And what we have to clean is usually not the best quality of cleaner to truly disinfect an area the way like would be done in a hospital. And I get it from a security perspective, there's certain chemical agents we don't want to introduce, but our reality is that in order for us to truly be able to eradicate some of these things that we see pop up in the environment, we do need some resources that would help us to better keep the environment clean.
Right now, before we start talking about the specifics of the coronavirus and basically how would we expect to react, I do want to get into the specifics of that, especially when it comes to, I don't know if there's going to be a power struggle between medical and custody. I actually want to go to Soto first and talk about hazmat responses and infectious disease responses. Hey, Soto, is there a difference when it comes to that type of response between, maybe a mysterious chemical like fentanyl and a coronavirus? Would there be a difference in response?
Well, one of the things is that, we have those policies in place that deal with something like that, like a hazmat response or, something like the influenza and the pandemics. We have those policies in place. And unfortunately, with the coronavirus being as new as it is and not knowing much of it, we know that it can be spread, obviously airborne, just like everything else. And us having that recirculate air in our prisons and jails, that's going to, just put us at a higher risk. So when there is a response we're just gonna piggyback on the policies that we have right now. And because we have those policies in place, it's gonna help us in the response. When we were talking about respirators, and the masks, some of the research that's been done is that those surgical masks that they have to be of a higher quality. Like Connie said, they have to be like that N95 respirators that actually block out anything that's in the air. But the main thing and I don't know if you want to get into it real quick or not, medical will definitely have to take a precedent to our response in security. We know that we have to keep the place secure, but when we're talking about a pandemic, we have to take our guidance from the medical department, the medical staff who are very well trained in how to respond to these things. But not only that, the education of our staff. That's what we're trying to do at our halfway houses now. And most prison settings are sending out, massive information, signs being posted on every wall, at every housing unit, at every entrance, at every egress. So that way people are getting more and more information on what it is that they need to do. Education is the main thing. And some of the simple things is our own sanitation, right? Teaching people how to wash their hands properly, how to keep their areas clean. A lot of this stuff, we don't know whether this coronavirus can actually survive on surfaces or how long they can survive on surfaces. So we're asking them to clean those high risk areas like doorknobs, handles, faucets that we're touching. All of that stuff comes into play when you're trying to educate your staff.
Right. I mean, speaking about education and staff, I'll go to Connie first and then Soto. We're also talking about maintaining control and order. So besides the stuff that you just mentioned, how important is it for custody and medical to know exactly where their role is? And at any point their role shifts where now I'm no longer answering to custody, I'm answering to medical.
So I think it needs to absolutely be crystal clear, because I think that's when the confusion comes into play. And when you are in crisis mode, the last thing you need is everyone walking around in conflict. Our reality is that you're trying to make sure that you contain something whether it's already in the facility, we want to make sure it doesn't get in the facility. If it's preventive measures and medical has the expertise, that's when I believe custody should kind of fall back, let medical take the lead, not in giving directives, but like, here's what we all need to do in order for us to be safe. And then however custody wants to implement that, as long as it's within the protocol or the standard, I don't think there's any problem with it. But I do think when in fact you have someone who is infected or who has now been contaminated, that medical needs to be able to take the lead on what happens with that particular offender.
Right. I'll be honest with you. I agree with you 100%. I also agree if it's staff that's being exposed or staff is the concern. I believe there has to be, again, we have safety and security, don't get me wrong, but we do have the medical side. I do believe that medical is going to have to step up and staff is going to have to be able to listen. But Soto, from your experience, could you see that as a problem where staff may not choose to take any of the directives from medical without having maybe a higher level security custody say, no, you have to get this done?
Well, that's once again the collaboration, and that's why we have shows like we have with you, Anthony, because we need to collaborate. We need to work together. And we can see that, you know, custody sometimes has an issue with the civilian side because, you know, they don't know. We've been trained in that fashion to take orders from our higher ups, take orders from our chain of command. And we need to kind of be retrained or basically learn new methods of how to get along because we all have one mission, one goal. In this instance, when medical is telling us, hey, you can't just do this, you can't just take, and Connie said the exact word. Most of the time with this virus, anything else that medical is trying to help us with, it's containment. It's all about containment. Some of our institutions may not have the proper facilities to contain. So if I have someone that's showing signs of anything of the sort, I have to rely on the medical department to say, hey, where can I best put this individual? What is the next steps that need to be? Maybe the next steps is to make sure we call an ambulance and get them here. In our areas right now, we're compiling a group of individuals that are going to be on a rapid response team to go to every facility at a moment's notice whenever there's called or signs of anything like that. We're getting proper training. We're getting taught how to have the proper PPE, which is personal protective equipment, how to don it on, how to put mask on, how to keep gloves on the entire time, how to decontaminate yourself after you've been exposed. These are things that are necessary. Most of these things are supplied to us by the medical staff, including all that education.
And because the facility is compromised at that point, because obviously it would be, I would assume there'd be maybe someone from a central office or a higher level that will ultimately come in and oversee and ultimately take control, because I'm assuming there could be some concerns on the inside. And if policy really doesn't establish that at this point medical takes control and at this point custody's got to step down or vice versa, which I really don't see it vice versa, but I would assume you would have someone from a higher level come down and take control of the scene. So you want to go first, Soto, and then I'll go to Connie?
Well, yeah, well, we also, remember, we can't forget what we've already been trained in, right? Most places, ever since Homeland Security became a big thing, we've all been trained in that incident command systems, right? Where now, whenever there is an incident occurring, you have an incident commander. It not necessarily has to be someone from custody. It could be someone that is very knowledgeable of what's happening and the incidents. We've all taken ICS 100, 200, IS 700. We've done all those steps to learn how to respond to major incidents. And not just us, we also have civilians that have done the same type of training, so we can work together hand in hand. And that incident command system is the best thing because you report to one individual, right? And they have the resources and they can compile them in certain areas where they know how to disperse them and how to deploy them.
Yeah, I remember me and you talking about this, Connie, where I even think that you guys, right, would have maybe a director or somebody from your medical department come in?
Yeah, so our central office has a medical director, and the medical director, in instances where it was needed, would always leave central office, come into whichever facility that was in that crisis mode, and would help navigate whatever the issue was. That would be the point person for the warden or the point person for Department of Public Health, sort of feeding the facility any changes in protocol, any changes in standard. And even if we needed to get any emergency shipment of supplies, whether it's being transferred from another facility within the system or transferred from wherever we had to get it from, that person, that medical director, was the person to make sure that happened. The director of nursing also came in. The infectious disease control nurse also came in. So there was a coordinated effort to make sure that we were able to contain whatever it was that came into the system.
Now, I'll start with Connie first. Do you think that there is any difference in what the perceived end game is for safety and security and for medical?
I don't think so. I think that sometimes there's this, I don't know, I think there's a misunderstanding at times that somehow medical is only focused on medical. I think certainly medical has the medical scope at their forefront because they're trying to address whatever the issue is at hand, but they're not void of the fact that we're working in a prison setting or a jail setting, and security is important, right? I think what it is that sometimes causes conflict is that medical is also placed in this space where they're the advocate. So like they're trying to advocate to get whatever they need for this particular offender or this population of people, right? And so it can look as though they're just advocating to get something for the inmate, whereas the reality is that if they don't advocate to get whatever those supplies are, whatever that treatment is, then we will have this situation boil into something that we don't want it to be. It's harder to contain when you've got an entire housing unit versus 2 or 3 inmates. And the slower we are to respond, the increased likelihood that we're going to have this become a whole housing unit issue as opposed to the 2 inmates that were housed in the same cell.
And let me ask you a question, Soto. Would you think that when it comes to, let's say, the coronavirus, would you think that medical may have their staff that's actually able to handle the spread better just on a personal level as opposed to custody is just really unaware of you know, the specific danger of medical? They're not trained to that specific level. Do you think that their level of I want to say fear would be a lot different than the level you would get from medical?
Absolutely.
Yeah, well, you know, we're all first responders, right? And we all went through that training to become that first level responder. But that doesn't mean they taught me how to deal with a coronavirus, right? I mean, that's kind of higher level medical assistance needed. But the one thing that we need to do is make sure that we are well informed, that our staff is well informed, and don't forget, the inmates need to be well informed. Because if they're not well informed, you know, they may be in a cell with a guy that's just sneezing, and all of a sudden they're like, oh no, they see the news just like we do. They have access to TVs and all that, the news. So they're like, wait a minute, this guy is showing signs of, you know, the flu or whatever the case may be. He had visits this weekend. We need to pay attention to those little subtle things so they don't grow out and become bigger issues, and make sure that these individuals are being vetted in the medical department. And our policies may have to change a little bit. I mean, just think about our intake process, where normally a guy coming into the prison or jail, we're asking them specific questions about maybe PREA, are you gang affiliated, are you doing this, are there any issues? Now our questions may have to be geared towards a medical staff person coming there, also being part of the intake process, and asking them, hey, are you feeling signs of the flu, or you feel heat rashes or anything of the sort that may show signs that this person needs to be contained for the next 13, 14 days to ensure that they have this virus.
I mean, all it takes is one situation for us to end up changing our medical intake form, because I know I went through an experience where a woman had come into the facility and ultimately she had like active tuberculosis, and she kind of flew under the radar because there were certain questions that weren't a part of the intake, which was, one was like, have you traveled out of the United States in the last 30 days, right? Like, that's not generally a question you just ask, but when you start seeing diseases coming into the system, you begin to ask those questions, because now you need to, you know, assess who was this person exposed to, or how could they have been exposed, and how could they be undetected, and why someone might not be registered with the Department of Public Health. Like, there are kind of all these stopgaps for us to identify when there's someone who has some sort of communicable disease. But if there's some sort of failure somewhere or some crack that they could have sort of slipped through, like, it forces us to reassess the documentation that we're using. Does this truly meet all of our needs? Does this gather as much information that we would need in order to make a fair assessment of what this person is coming in with?
I would also like to add, if there's not a good relationship between custody and medical, custody may not trust medical, and medical says it's not something to worry about. Like, if an inmate has a cough and custody goes ahead and brings the inmate over there, and, you know, all of a sudden medical's like, no, I promise you it's just a cough. And then you got custody just not trusting medical enough to believe that. And then there's a little bit of a resistance. Would you think that happens, Connie?
It happens a lot. I mean, I think, one, it's kind of fear driven. Like, okay, this person's coughing. I don't know whether or not I can trust it. Medical says one thing, but how do I know for sure that medical has done their true assessment? They've done their due diligence, right? I think at the end of the day, yes, it does boil down to trust, but also too, I think there has to be this acknowledgement that as a doctor, as a nurse, if I've made an assessment and I've not identified something, like, I'm also putting myself, my licensure in jeopardy. Am I really going to do that just to spite someone, right? Like, in all fairness, like, we're all supposed to be professionals. And at the end of the day, if it's a cough, it's a cough, right? There's a series of questions that would get to the point that, okay, it's just a cough. Usually when they've done that, they've already ruled out a whole list of other things that it could have been. Do you have a history of this, a history of that? Do you a substance user? Do you this? Like, there's so many questions that medical has to ask from an intake perspective before they get to the point where they say, okay, it's just a cough.
Now, hey, Soto, speaking of that, before we have concerns like this, that's why I think it's very important that we also have some form of cross-perspective training or some level of training that brings about that respect between both parties. Because my concern would be is that if you don't have the two parties respecting each other, like I just mentioned, they're not going to trust the other department to say, hey, this isn't what it is, or this is what it is. And I'm sure in your career, you've seen that.
I've seen it many times, but I've also seen the positive effect of when there is a great relationship between custody and the medical staff, not just the medical staff, but also the either social services or any other civilian worker, the education department. When those roles and those individual people sit down and talk and they see what their goals are, you know what I mean? We can't do what we do without their help. It is a support, right? That medical gives, that education gives, that social services give, but they can't do their job unless we support them by providing the security and that aspect of being safe and being able to, you know, embark into their duties day to day. So I've seen both sides. I can happily say that I've seen the better and the positive because we are professional. Like Connie said, we're becoming professionals, continuing to be professionals, talking with each other, working with each other. I've seen that positive attitude goes a long way and also keeps the population, our inmate population, both of us, they're getting along. They know what they're talking about. We will listen. And it keeps that, you know, reach as well as safety issues under control.
Yeah. Right now, Connie, when we talked about like the cough and maybe people that don't have it but think they have it, I'm sure at times like this, medical's flooded with requests from from the inmate population, correct?
Absolutely. So this is a time where if there is a risk in a particular facility that you may be calling for extra folks to come in and float in to be floaters to help support whatever that assessment need is going to be. There's been a point where we've actually taken nurses off of every other post and had them only doing that one assessment. Everyone was assessing whether or not this unit was infected, right? And I think it's just the flexibility that you need in any facility when you find these things that are coming up. I mean, I think it's for us, the experience was that Cussie was actually really supportive, because you did have officers who were still working those units and wanted to know that they weren't sitting in the middle of contamination all day. They didn't know, they wanted to know that as inmates came to the desk to ask for whatever, that they weren't getting exposed to whatever it is. And so I think there's a sensitivity that I think medical has oftentimes when we are in this crisis state. You've got, because you have to contend with the inmates who are saying, I need to see medical. And you're also contending with the officers who are actually just escorting them over to the medical unit, right? Like, we need this guy seeing he's been coughing all night, or, you know, his cellie told him that he's been coughing all night, or whatever the situation is. And we have to be responsive. We don't have a choice but to be responsive. It just delays provision of any other kind of service, any other kind of treatment that might be needed.
And it's great that you're saying that, because you're not just going to get the request from the inmates. You're probably going to get the request from custody staff who's be like, hey, got an inmate coughing on my wing. And Soto, yeah, but it's going to happen. And Soto, obviously, with all this stuff going on and medical probably getting hit up with these medical requests, how's that going to affect the operations of the prison?
Significant.
Well, you got to understand that the requests are going to go up dramatically. You know, what you normally see in a medical department, or your doctor call line or your sick call line, that's going to go up dramatically, just on the fear factor. Just because, you know, I had a runny nose yesterday, I want to get checked out. Or inmates are saying, yo, man, you got to go get checked out. You can't just sit on the tier like this. You may be infected. I don't know. So again, it's just a matter of having those precautions, taking precautions, and making sure that we have things in place. Like Connie said, have extra staff coming in, right, to deal with issues like that. We know that if we know for a fact that something is going to occur or something's going to happen, we need to prepare as best as we can. In the facility, I mean, simple things like we normally clean in a facility. Well, guess what we should be doing at this point? We need to clean a little bit more, right? Set a schedule aside. If we need to know what the CDC is providing as guidance, these are the detergents or disinfectants you should be using, then, you know, us as administrators, we need to make that exemption where, okay, for the next 30, 40, 50, 60 days, we're going to be allowing these particular chemicals coming into the facility, because that's what's recommended by the CDC to combat this pandemic or influenza. And, you know, it's as simple as making sure that we are following all the guidelines, having those SDS sheets for everything, every chemical we're using. Educating our staff. I'm going to go back to making sure that we are all informed, including our inmate population, as to what we're doing, how we're cleaning, how we're taking care of those high-risk areas, you know, where visitors are coming in, posting signs outside. I mean, as far as the halfway houses are concerned, we're asking even a specific question for everyone that comes into the building. We're asking them exactly, have you visited anywhere that the CDC has proclaimed as a high-risk area within the last 14 days? And if they do say, yeah, I've been here or there, then, you know, we take the precautions. Maybe we won't allow them to come into the facility, just to protect our staff and our inmate population as well as our workers.
Hey, let me ask a question. I'll start with you, Soto, first, and then go to Connie. When we're talking about quarantining individuals, let's say, you know, we do get an outbreak and we have to start quarantining individuals. Do you think you'll get kicked back from custody when you have to start telling them that they have to stand in those areas that are quarantined?
Well, you always get this usually when, you know, we've had other instances and other issues that have come up. Like, you know, you got people with either the chicken pox or TB, or, you know, we've had them to quarantine them for anything like, you know, MRSA or anything like that. And our staff can always say, hey, I don't want to work at unit. Hey, I don't want to be there. I may be exposed to it. But our job is to inform our staff, this is how we take care of you, by having you well informed as to what may be contagious, what's not to be contagious, taking those precautions, universal precautions, making sure that they have personal protective equipment, making sure that the medical staff is there to explain anything that's out of our realm to explain. But I've dealt with this many times, and, you know, we shouldn't force people people to work in areas like whenever we have a chicken pox outbreak or something like that, we make sure that our female population isn't working in those units, right? God forbid. And then we ask for volunteers. There's a lot of people that will say, you know what? I understand what this is. I understand the risk. I am well informed. I'm willing to work that area. So, you know, it's always it's easy. You just have to manage people, and that's what we do.
Mm-hmm.
Right, and I just want to mention the reason why we may not have females work those posts just in case they're pregnant. And also sometimes we even go if you have young kids at home as well. You know, if you have young kids at home, we may give someone the benefit of the doubt and not want to put them in an area because you got kids that have developing immune systems. But Connie, I don't think you would get that problem with medical staff, would you?
No, we've still had that problem with medical staff. I mean, because even though medical might be informed, so in some systems you get hazardous duty pay, right, versus not. And some systems where you don't get hazardous duty pay, it's almost like why would I be willingly wanting to put myself in even more hazardous space where we know there's a possibility of some contamination of sorts. I think what I've also dealt with is having like the union contact us and say, why do you have, you know, these ex-nurses or ex-medical folks in this area, you know, questioning, you know, what decisions were made, how they're being protected. I mean, universal precautions are always in place. That's a given. And any other guidance that we get to make sure that the staff that are providing treatment are protected, we make sure that they have whatever they need. I mean, if it's just a matter of fear, which, I mean, some is irrational, some is not, but it's human, right? And so we do the same thing if they've got small children, and particularly with nursing staff who are mostly female, you know, are they expecting? You know, there's a way that we try to navigate that with sensitivity. And then we also do ask for volunteers. If there are people who are familiar with this disease and you feel comfortable going into the area, you know, would you volunteer? And there are people who will say like, oh, I've dealt with this, you know, 5 years ago. It's really not that serious. I don't mind going, you know, so we have the same experience on the medical side.
Now, how do you deal with those inmates that just keep on making like false claims, like a hypochondriac, if you will, where, because you're going to get those inmates that are just going to keep on coming in and they're just tying up with what you really got to do with the rest of the population. Because me and Soto, and I'm sure you're aware of this, Connie, where, you know, you get policies put in play and then you get inmates that manipulate those policies. You get inmates that, you know, claim PREA because they want to manipulate a move. Well, what about if we're going through this high emergent situation and we got this inmate that's just, I don't know if they're playing a game, but you just can't convince them that they're not sick and they're just making it harder for you to go ahead and move forward? How do you deal with an inmate that's just like that hypochondriac?
So, I mean, usually those inmates have already been identified and there's usually a proactive approach with those inmates. So those are the inmates who are usually known to mental health already, and they are usually already connected with their psychologist, their social worker, or someone who would proactively meet with them to make sure like we can keep those false claims to a minimum. I mean, there are other inmates who, you know, aren't mentally ill, but just have their own fears that when they do come forward, what we end up doing is kind of tracking how many times we've seen this particular inmate. If we've seen them more than twice, because usually, you know, you'll have the inmate come on first shift and then again on third shift or something, not necessarily consecutive shifts, but trying to make sure they get seen or trying to make sure they get whatever they think the treatment is that they might be missing out on or whatever. And then at a point, there's a conversation with the officer in the unit just to say, hey, listen, this guy or this female is they're stable. You know, there's no need to send them back down. You know, and that way they're not kind of bottlenecking the system for people who really need to be assessed.
Right. And Soto, obviously custody really has to just constantly relay that information no matter how many times that inmate comes up, because they're not in a position to say, you know, the inmate doesn't need to go to medical. So they're really waiting for medical to kind of co-sign that, correct?
Mm-hmm.
Yeah, but it also entails documentation, right? You have to document, you know, if this particular inmate or resident has gone to medical once or twice that day already, there there's no need to go there for a third or fourth time, and documenting that, making sure that we know that he's been to medical already, he's been seen, he's been diagnosed. You know, that's how you're going to deal with issues like that come up with that individual that just continues and wants to use the system.
Yeah.
Right now, a lot of people think that inmates are shut out from the outside world, and we know that they're not. So they know what's going on. They know about the coronavirus. So how do we balance? Because here's the scary part. When you're working in prison or jail, you know, at any time, the smallest thing could ignite pandemonium. So at one point, it's like, I want to educate these inmates. I want them to know what's going on, but I also don't want to put a spark to what could potentially blow up something huge. So how do you balance education with fear?
Who's that question?
Whoever wants to go first. Connie?
I mean, it's always difficult to balance the education with fear because, you know, with some of the offenders, you can talk to them a million times and they're still going to be fearful for whatever reason. I mean, whether they just don't trust the system, they don't trust medical, they don't trust anything, like there's nothing we could do about that. I think the documentation is important. And I think anytime that we can come up with, you know, some sort of simple write-up about it, that, I mean, I think for us, we had started doing things at a 5th grade reading level, right? Instead of just posting everything the CDC says on this one sheet, because we know a lot of people just can't understand it. It was, how do we get what the CDC said into something that could be translated into sort of this 5th grade mindset, you know, at that reading level, at that comprehension, so that there are no continued questions. And when we've exhausted all the efforts, you know, our reality is that we still just have to move on, because a system can't be bottlenecked in the event that we do find someone who's actively, you know, going through the motions and need to be treated.
What's your thoughts on that, Louis?
What I'm saying, what I say is, it's this: the lack of information is what sparks up the fear. You understand? So just like Connie said, just making them aware of what's going on. They're going to see it in the news. They're going to talk to their family members on the phone. They're going to talk to them during visits. They're going to be aware. It's up to us to make sure that the more we say about it, the more we talk about it, whether it be through a simple write-up, a simple memo. Some institutions have this PC, the prison channel network, where you can send some kind of, like, if you want to call them infomercials, short things in our groups, talking about it in our groups when our prisoners are going, or our inmates are going to our group sessions. Just a small word: hey, just want to make sure that we're all trying to follow these hygienic procedures that we put in place. Make sure we wash our hands all the time. Maybe we don't want to shake hands with everybody anymore. We just want to say good morning, good afternoon, without, you know, having that contact right now among the inmate population and even our staff. The more they know, and the more we say it, a well-informed person, it's going to bring the fear down to a minimum, and you won't have that mass chaos of, oh, you guys aren't doing anything, or you guys aren't telling us anything, keeping us in the dark. You don't ever want to hear that from your staff or the inmate population.
Are there, I'll go with Connie first, then Soto. Are there any protective measures that we can get visitors to commit to before they come into the facility?
I mean, it's very difficult to do that unless we're gonna, so I mean, we could always say, here's the things we want you to do, but unless we're providing them with whatever that protective measure is, once they get to our front doors, there's really no way to mandate that. Because, I mean, that'll be the first thing. If I can't afford whatever your mandate is, what does that mean? Does that mean I can't visit? Does that mean, and if it means I can't visit, will I tell you that I didn't actually protect myself in whatever way you've recommended? You know, so that, I think, in of itself would be a challenge, just making sure that visitors are following through with something. But I think, you know, maybe there's a way to sort of craft the message so that visitors understand how much more difficult it would be to protect their loved one if they actually brought something that could possibly create a situation in a facility. So like if they came in and they were sick, if there was a way for us to tell the story about the challenges of containing in a facility, I don't know if that's the best way to go, because I know then that could be manipulated and used for other things. But, there's got to be a way. I think the message can be clear to visitors on expectations in order to visit.
See, my concern is, and I'll go with this with Soto, I could actually picture custody, because I could picture myself doing it. By the way, when I say I could picture custody, or the reason why I ask these questions is because I can actually see myself doing it. That's why I'm okay with asking these questions, because I know there's someone in the audience that thinks as I'm thinking. And if I could get to that one person, that's great. But I could actually see custody maybe at visits, and they see that person that just doesn't stop coughing, and they may make that call to stop visits, because I don't think they can tell them, hey, before you go in, you got to go to our medical department. No, they're probably just going to say, you can't get the visit. Can you, hey, so that's a good question. Do you actually think that custody may turn down visitors on just a simple cough? Do they have the authority to do that?
Well, that the officers themselves that are maybe registering the people coming into the visit program not have that authority to stop that person from coming in to visit. But I would definitely question the individual, ask for a supervisor to come present, and the supervisor may have that option to call the on-call and say, listen, I have a person that really seems like they're not, it doesn't have to be the coronavirus. It can be any illness. Somebody that's asthmatic can come in and cause a visit hall. You may be there for an hour too during a visit, and now you're causing some sort of medical distress that we have to tend to. So I think that the supervisors making that call to the on-call will be able to stop someone from coming in if there's questions as to, especially in this time and age, we're going through this influenza virus. But again, posting signs, making sure that they understand that, hey, we tell them that if they're improperly dressed, that they can't come in, right? So if we can say that, then we can probably say, if you look like you're in some sort of medical distress, or you look like you're in some sort of having some illness, we're going to probably not allow you to come into our visit. But I think that you should be proactive about it. You should be talking to staff about it. You should be asking the questions of the visitors. Hey, have you been feeling sick? Any fevers, any coughing, nothing like that we have to worry about? And if they say no, well, you've done your part. We've gone to the point even at our facility where we have hand washing stations available so that people can use that before coming in. We've got some of the different disinfectant gels that we use, like Pure Gel and stuff like that we offer prior to going in. I mean, even when we go on a cruise right now, you go on a cruise and you go to eat dinner, they won't let you in unless you take a shot of Purell.
Wash your hands.
That's exactly what they do, right? So these are precautions that we do that we may have to put into practice even at our prisons.
Well, I hope by asking these questions, I don't put fear into people's hearts. Like, I hope that all of a sudden I don't have hey, I watched Gangi's video and I saw a visitor coughing and I didn't even think about that before. Now, all of a sudden I'm calling everybody to just stop this visit from happening. But I want to actually, before we go into closing, I want to just touch on some more specifics about how we would react. Because obviously our environment is not really ideal for this because it's just the amount of people. Like, I know right now on the streets, they have this self-quarantine. Now, I don't know if we can do that, if we can send an inmate back to their cell because they have a cellmate. But I'm assuming the people that they send back home to self-quarantine, don't they have a family? So I don't know, would there be a difference? So if you saw somebody and you didn't know, and it's kind of like that universal precaution, do you hold them in the infirmary or in the hospital or whatever your facility has, or do you send them back to their cell on whatever that is, self-quarantine for 14 days to figure it out?
In a facility, I can't imagine that you're going to send anybody for self-quarantine. I mean, I think the biggest challenge would be some facilities have these isolation rooms and some don't. And so even if you have isolation rooms, do you have 20? Most likely not, right? And so is there a way for us to isolate in a medical infirmary room where they have a negative pressure room or things like that, where that could kind of help suppress whatever the contamination is or contain it? I can't imagine anyone sending an inmate back to the housing unit to self-contain.
Yeah, because I'm not understanding that, to be
Yeah,
honest with you. Go ahead, Soto.
Yeah, I don't think that, you know, anyone in a prison setting or a jail setting will definitely do that. No one can do that. And I'm going to say, hey, go back to the unit, stay in your cell for 14 days. Don't come out at all. That's not going to happen. But you know that people are above our level right now are having meetings all throughout the week, coming up with these plans and the what if scenarios. And what if I have a case in one of our institutions? What do we do with that individual? Does he go to a facility that the CDC has designated, or do we take them to a particular hospital? Is it more than one person? Is it more than 10? There's going to be a cost factor with that, because obviously we're in charge with their care and custody. So we're going to have to send officers into these areas. So trust me, there's plenty of meetings that are going on at the administrative level right now, coming up with scenarios and what do we do in instances when that happens.
Yeah, because the one thing I'm not getting from the news, and we're not going to discuss, it's not just out of curiosity. The reason why I asked that question is that you get somebody that they think may have it, but because there's that 14-day, they send them home for self-quarantine. To me, it doesn't make any sense, because they have a family or something, you know, it's like you're exposing the family. But I just want to get it clear that, you know, obviously in our facility, even with limited space, we would never send an inmate back to their housing unit, because obviously it doesn't only affect the cellmate, it affects the housing unit. And I believe we're also very limited in space. Connie, I don't know, but some jails have infirmaries, some jail has hospitals. Are you able to tell me the difference between the two?
So usually like an infirmary is where like the inmates can go to get like more like just basic treatment. If they need to go into an infirmary setting itself, like usually an infirmary set, so I'll back up. So there's different aspects of medical care where like you can just go for treatment. Maybe someone's just not feeling well. I don't know, they've got to have a bowel prep for a procedure the next day. So they might be in sort of the infirmary setting. When it's the hospital setting has more of the mechanics of a true hospital. So like if someone is, I don't know, maybe getting dialysis or they need some special sort of treatment, and there are particular rooms that are established more like a hospital room would be a setup, as opposed to an infirmary room where you just kind of going in for treatment. You'll be there only for a couple of days. The hospital is more set up to care for someone for the long term.
Right, and obviously, Soto, we deal with that too, because worst comes to worst, when, you know, certain facilities, the infirmary may not be what's needed. You always have one of the facilities, I'm assuming in the state, if not more, that have a hospital setting, or at least a contract with a hospital where these inmates can go within each region. I'm assuming, like, if it's not the contract vendor, maybe it's just a hospital within that area that we're able to contract to and send the inmates out. But my concern would be is that, and again, we'll start coming to a close now, is when we start running out of room. So the concern is, okay, we may be able to handle a few, but when we start running out of room, I like what Soto said, where you may have to make one facility a designated facility, which means that you're going to have to take those inmates out of that other facility and transport them to another facility. So it's not an easy thing to maneuver. It's a lot of movement going on, and that's definitely high security. So you're bringing in teams from all over to do these escorts. But I'm sure, Soto, when we have a pandemic like that and we're starting to run out of room, I actually agree with you. I think the best idea would be to try your best to secure a facility that you can place them in, and then you have to take those other inmates out, correct?
Yeah, that's the best case scenario. You know, if you have an empty unit or an empty facility that you can populate with who you believe or who you want to quarantine, because I don't think you'll ever find a hospital that can, you know, the hospitals are finding them. That's why they're sending people home in quarantine, self-quarantine, because they can't possibly have that many rooms in a hospital where we're going to put you up for 14 days here just to see if you are infected or not. So in a prison setting, that would be the best case scenario, having a vacant unit, housing unit, prison, jail, where we can swap out the residents, those that are with the signs of whatever influenza may be, have them there, and keep our other institutions free and clear. And, you know, you also have to establish medical protocols in the whole nine. And again, you run into the factor of, well, who's going to work there? You know, besides transporting these guys, who's going to work in this facility, and who's going to put themselves at risk, you know, if these individuals are infected with the influenza.
I was actually I think you bring up a great point too, because I was actually getting ready to ask Connie where would medical play role? So if you have an inmate now that possibly has the coronavirus, you know, how do you organize that transport? Is that a medical to medical transport where the one facility is ready to receive them? I mean, it wouldn't be an administrative or a custodial transport. It would be medical to medical where you guys would have the approval. And then how would you guys organize a quarantine trip?
So, I mean, I've had the experience of having to move an entire facility, and it's no easy feat. I mean, aside from all the classification issues that you deal with, the security issues, the risk group issues, you name it, right? And then to add insult to injury, you have medication that has to be transferred to wherever these offenders are going to. You've got treatments that have to get now moved to these new places. And then for us, when it comes to medical to medical, there's still always going to be a custody person there, no matter what the situation is, right? Because medical is certainly just not equipped to do a security transfer without having, you know, someone there with us. I've seen it where you have the officer. So if we've got protective gear that we're wearing, we'd have it on, the officer would have it on so that everyone's protected in the transfer. It would never be that medical is protected and we're riding with this offender to whatever transfer facility he's going to be going to without having an officer and the officer be protected as well. So we've done it, but it is quite the challenge making that happen.
Would it be, hey, Connie, would it be protocol too? Just want to make sure. So sometimes I ask the question, but I do know the answer. The answer got to come from you guys because you guys really are the experts. But if you had a inmate that, let's say, does have the coronavirus or even anything, TB, whatever it is, and they have a cellmate, is it policy now to get that cellmate to medical immediately to find out if they have any concerns?
Absolutely. So inmate and cellmate get assessed, and if there are particular offenders that inmate is around often, we usually would test those inmates as well. So it wouldn't be just who you're housed with, but like if this is who you're in the day room with most of the time, or this is who you go with the programming with, like we usually try to make sure we get everybody and test everybody.
Now, when does it start to become a concern where it's like, okay, we got 3 or 4 inmates, we're going to have to shut this unit down? Like, when does it start becoming a concern where you quarantine the unit now because there's just so many inmates having it?
Right. So when you confirm that there's X amount of inmates, each protocol will say what you need to do in that situation. But once you've got confirmation that there has been someone identified that has an active contamination or something, we usually make sure that custody is aware, which that usually is escalated. So my experience has been working directly with custody leadership, with the DEP warden or the warden or programs or whoever I needed to make sure that we were all on the same page about what the next steps would be with that within that unit. And certainly we would have the officer also. So medical actually made sure the officers were good. If there was any immediate concern that an officer had, like we wouldn't ask some questions about their own medical history, but if there were some signs or symptoms that the officer had concerns about, we actually sat with them one-on-one to make sure like they knew either, yes, they needed to seek out medical attention immediately, or 2, whatever they were concerned about was not relative to the contamination that was in the unit. And I think because we had a fairly good relationship with the custody officers and leadership, like they allowed that to happen. Now, on the flip side, we did get some pushback from our central office that kind of was like, okay, so you guys are there to treat the offenders. You're not there to treat officers. They were more concerned about the legal implications for if someone missed something. So if the doctor missed a sign or symptom that, and then told the officer, well, you don't need to go seek medical attention, you know, what is the legal, I guess, liability that lies within that organization or within the scope of that doctor or that nurse. So there's kind of like, it's challenging. It can be challenging depending on what, but for the most part, we make the decision to either shut down the entire unit and assess everyone, or we will take out those who were in close contact with the contaminated person.
You know, and what's great is we went from person to location, which is great because yes, we do have the person, but we could also have a location that's affected. But one more question for you, Connie, and then maybe, I don't know if Soto could complement it, but what happens if, I mean, obviously the inmates we have a little more power over when it comes to dealing with medical. They're state inmates. We can, you know, enforce that a little bit. But what about if custody doesn't want it?
They don't want what?
They don't want the help from medical. What about if there's a chance that custody could be, they're in a unit, the unit's infected, and now medical now has to, you know, check on that custody member, because I'm assuming that would be part of it, and custody doesn't want it, custody refuses. Can medical or can higher level custody force that officer now to say, hey, you got to go with our medical, you got to let them check you out?
So my experience has been if someone had refused, like a custody officer had refused to be assessed, the DOC administration would then get involved and actually take the officer off post and have the officer go to the emergency room. So although you can't make them, I guess, submit to any sort of medical assessment internally, because then there's that question of whether or not the officer is fit for duty. And usually fit for duty opens up almost like Pandora's box. And so officers would generally go ahead to the emergency room, and they had to provide documentation to their administration once they return to their next shift.
This may be a stupid question. I'll start with Soto first. I don't know if Soto's able to answer this, or I don't know if he wants to defer it over to you. But when you have a quarantine, is there any forfeiture of rights?
Yeah, well, you know, like you said, our inmate population, we have some, we have rights over them, and their medical files are within the medical department. So any quarantined person, they're going to have access to it via their files, the medical files, or the electronic medical records. So on that aspect, we wouldn't be worried about that. But just to add on to the staff, Connie hit the nail on the head when she said, if you have a staff member that is refusing medical treatment, we would take as an administration action with that officer, because it's always about the public, right? It's always about everyone else's health as well, not just that officer, but everyone else that works with that officer. So it would be definitely a job action, basically, by saying, hey, you need to go to the emergency room, you need to get cleared. You cannot return to work until you show us that you're fit for duty. So, but as far as a quarantine, and you know, if you can show and justify that, hey, these officers or this civilian or this teacher or this nurse was exposed to something that is now basically being watched over by the CDC and everyone else around, then it's unfortunate, but it's going to be something that's going to have to be ordered. Hey, you have to get treated, you have to get seen, you have to get checked out and cleared.
Yeah, because my concern would be is if you have an affected area and you're checking the inmates, I'm wondering if you can mandate staff to be checked because it's the area now. So if I have a few inmates that are affected in this one area, like you said, you need to check staff, you know, just to make sure everything's good. And if staff says, no, I don't want to be checked, do we have a level of authority over that to say you have to be checked because you're in this affected area?
So I honestly think that there's something in, once a quarantine has been initiated, I almost think that you don't necessarily have the option to not comply with the quarantine, quite honestly. And I'm sure it's probably written differently in different directives, but I would have to err on that side of caution that if we're saying this area needs to be quarantined, that means everything in that area, including the officer. I can't imagine that you could just opt out. But if you did opt out, I would see you being relieved from duty almost immediately and being sent to the emergency room and not being able to come back until you're medically cleared.
Well, I think it's just a good question because, you know,
Yeah.
for people that don't know, I think the fact is that if you're in an affected area, I think it's best that custody does obviously get checked, because now you're going to take the threat outside. So what's the sense of having the quarantine if you could be affected, right? Right, Lou?
Yeah, that's absolutely right. So, you know, it's a matter of public safety. So you're going to have to get treated either way, either at this spot where the place is quarantined, or we're going to relieve you from duty and you're going to end up going to the emergency room and definitely won't be able to come back to work until you're cleared.
So one last question before we get to our closing is, I know you have policies and procedures in place. Some may model off of other infectious diseases like TB and influenza, maybe just a little bit more of an advanced measures, obviously both preventive and reactionary. But trying to read my notes here. Give me a second. But before we go to closing, would there be any bit of a difference in that response now because of how infectious this coronavirus is? Is there something that, like, how will we step up our game as compared to the other policies we already have in play? Like, what is it that we would have to do different for this one?
Well, like I was explaining to you earlier, you know, we are going to piggyback on those policies that are already in place, but we're going to monitor and keep ourselves informed by everything that's being said to us by that medical staff, by the CDC, what their recommendations are in following suit. This week, I was assigned to the rapid response team here in New Jersey for our halfway houses. And like I said, they're training us on what to do in case there is an outbreak in one of our facilities, what our responsibilities are, what our role is as soon as we get to the site. So it's a 24-hour, you're on call, you're responding to the site, you're trying to contain either the individual or the individuals involved, and making all the notifications that are necessary, not only by the state, but also by the federal government. So these are things that we have to step up and know what we're doing in order to combat this little influenza that we're into.
What's your thoughts on that, Connie?
I mean, I can imagine that, you know, for certain protocols that it says, you know, you have X waiting period. With something like coronavirus, I would imagine that the waiting period may not be 48 hours. It might be reduced to 24 hours. Like, I can see many modifications being made to protocols that are currently in place, just because, you know, I think the level of alert is much higher than, you know, if it was just like the flu, or, you know, if it wasn't something that was spreading the way it currently is spreading. You know, I think the response just has to be much quicker than many of the other protocols might dictate for other possible outbreaks of stuff. You know, like, because I know, like, for tuberculosis, that was different. For like lice and scabies, like, it's like all these things that, and MRSA, like, right? So we respond, but there's a protocol and you kind of wait to see, you know, what the disease progression is and all this other stuff. And I think with this particular virus, because we don't know as much about it as we do about others, that, you know, the expectation is that you respond immediately.
And I would also request, on a little side note, a little preventive measure, something we didn't touch on just yet, is I would probably have the inmate details out a lot more cleaning. You know, I mean, what do they got going on? Clean, you know, just keep it cleaning. Hey, before we go to closing, a little side note. So we had a little debate in our office today, just a little question. And I'm going to give you guys the question. I actually thought my answer was spot on, but I seem to get outvoted. I want to get from both perspectives. So if you have a code, but you have a limited response, so you only have one team and two codes go off at the same time. One is an inmate trying to kill themselves, so he's trying, and the other is an assault where inmate's being badly assaulted. Which code do you go to? If you only have enough team to go to one, they're both being called at the same time. Soto, you want to go first?
Yeah, you love these what if questions, but, you know, at the end of the day, you have to deploy your resources to where you think life is in jeopardy. So, I mean, who knows what the code is? That's why we don't even say what the codes are. If you code a code, I don't know what codes you call, but a code yellow, code blue, code red, or you have numbers for your codes, 33s. The reason we do that is so that we don't really physically know as a response team what we're going into except for the general. Is it a medical? Is it a disturbance? Is it a fire? So if you're going to tell me that I have somebody trying to commit suicide and is already ready to hang up, and you have somebody that's involved in a fight, if I go by time-wise, I'll probably go and try to save a life first before I go try to disrupt a fight. So,
okay, I want to, because I'm going to have to sway this a little bit, so bear with me. So I wanted to say that it was assault, so let me just color my story a little bit, because I can't get anybody to take my side on this. So let's just do it this way. The code gets called both at the same time. The one code, whatever, is a yellow for this and the red for the assault. Let's say you're on the radio and say, is it assault? Yes, the inmate's getting stabbed. It's a weapon. Let's just make it an extreme assault. So we have a victim, and then we have someone that's trying to kill themselves. Where do you think the biggest liability is? Let me just give you my answer to show you where I saw it from. And obviously I was outvoted on this island. I was going to respond to the assault first because you have a victim where the other person is doing it to themselves. Okay, what's up? What's going on, guys? You know, it's not, come on, man. I mean, how am I wrong, Connie? What's your thoughts on that?
So, I mean, my first response really was to go for the suicide, because I feel like that's where you can actually save the life.
Forget about the inmate being assaulted. He's done. Is that what we're saying? Don't worry about it.
So fights are part of like the environment. Like, they're gonna be fights. They're gonna be like, not to say it's okay. Like, okay, there's an assault, no big deal. But I feel like the inmate who's committing suicide or attempting is in crisis. And if we could save a life and prevent a death, as well as the investigation that's going to ensue following that completion, right? Like, there would be, I could see the benefit in going to try to prevent the suicide.
Yeah, I think it's like, obviously it's a damned if you do, damned if you don't. I don't think you'll get in trouble either way, whichever one you respond to. But the reason why I'm specifically saying it's an assault is because I'm thinking the end result, if there's a potential for a lawsuit, hypothetically, you could have the family saying, well, one was this person's own actions, where this one is a victim who was no fault of their own. So I chose this, but then someone also mentioned to me today, which kind of made me sway my argument, where's the most likelihood of the death happening? Where it's going to be the suicide over the assault, and I see Lewis already shaking his head. Is that what it is, Soto?
That's what I'm saying to you. We don't respond because of liability purposes. We respond to the incident. And I got to say, caveat, that would never happen at my institution. We would respond to both, because I would call it count up, right? Everybody's locked in. Whoever's available is responding to one or the other. So we're going to be responding to both, but we don't respond by a liability. So again, you got to answer the question as you posed it. Which is the highest risk of death? The suicide, because you already said he's trying to commit suicide. The assault, whether it be a stabbing or whatever, you may have more time.
Yeah. All right, so I did post up a poll, by the way. It's on my YouTube channel. I believe the poll is starting to even out. So I'm curious to see where it goes. I think we have over 100-something votes, working its way to 200. It was split in the middle when I saw it. I'm sure after people watch this video, it's going to go one way or the other. But I think next time we do that, at the end of each episode, I'm going to try if I can come up with more of these twisters. But I have another one for the next episode. I think you'll find it interesting. But you guys have any closing thoughts?
I'm just saying, just for my fellow sisters and brothers in blue, please use universal precautions. Watch yourselves, stay safe, and God bless.
Yeah. I mean, for me, it's just, no matter what we do, we can't work in isolation. And so our reality is that we do need to forge better relationships between custody and civilian employees, just so that we can reap the benefits of the collective expertise. That's all.
Yeah, as I said too, just kind of go the extra mile, keeping the place clean. Be vigilant of who's coming into your facility. You have a lot of traffic going in. We discussed that before. I think jails, prisons, they all have their risk. A lot of visitors coming in and out, a lot of unknowns. But in the end, I guess the end result is if something does happen, hypothetically, which we don't want it to happen, just stay calm. You know, have a protocol that at least, all I'm asking for is this. Have a protocol that at least establishes a level of authority or chain of command. That's it. You know, I know sometimes we have to come up with things on the fly, but the last thing we want is that policy that doesn't establish a leadership position when something happens. We could deal with all the stuff on the fly as long as we know that there's a level of authority that we're able to report to. So if you have policies and procedures, please make it as clear as possible as when this happens, who takes which role. And then hopefully we're able to navigate the ambiguous situations as they come. All right, as always, guys, the show is Tier Talk. If you haven't, please subscribe, interact, engage, comment, hit that bell. Bell's going to notify every time I post a video. And stay safe.